Alright, so we are talking about acid-base balance disorders, and we are discussing the carbonate-bicarbonate buffer system. There's other buffer systems in our body, such as phosphate and protein, but this time we are discussing carbonate and bicarbonate because that is what regulates the ABG. So why is it important to know acid-base balances? Well, they will help the healthcare team identify the acid-base disturbance that is going on, and knowing the acid-base disturbance will help us narrow down the causative factor. We also look at the acid-base balance to help determine the degree of compensation that is going on. The information regarding ventilation is important, information regarding oxygenation, and then the acid-base balance of the individual. These are all important things for us to know so that we can help provide excellent care. We need to refer to Table 4-4 and Table 4-5 in the book. It's page 91 and page 92. And they just talk about the acid-base disturbances and compensation and the normal values for arterial and mixed venous blood. And then in Table 45.2 in your ATI book on page 283 talks about the types of results. So important to know that pH stays within range due to homeostatic mechanisms, buffer systems. The range is 7.35 to 7.45. The higher that number is, the more basic we are, the less hydrogen ion concentration our body has. Hydrogen ions are acidic. So the lower that number is, the more hydrogen ions our body has. Our kidneys regulate the bicarbonate, and the number for it is 21 to 28. So the higher it is, the more basic, because bicarbonate is a base. And the lower the number, the more acidic. And then our lungs regulate the carbon dioxide carbonic content, and CO2 is an acid, so the higher number, the more acidic, and the lower number, the less acidic. Here's a video that you can watch on your own time. It's about the bicarbonate buffer system. It just kind of rehashes what I'm saying. It does have a formula in it. You do not need to know the formula. It's might help you understand the concept better, but it is definitely not necessary. So this is a picture of a modified Allen's test. I actually meant to talk about it in class, but I forgot. So anybody who does an ABG, your respiratory therapist, you, whatever, you will need to perform a modified Allen's test. Excuse me. So the way that this is performed is the person performing the procedure is going to occlude both the ulnar and the radial arteries. When you do this, you're obstructing blood flow to the hand. So the hand needs to basically turn white, as it is on the radial side in this picture. So then, while you're applying occlusive pressure to both arteries, you're going to have them relax their hand, and their hand should blanch. If it's not blanching, then you're not occluding and you need to apply more pressure. So you're going to release the occlusive pressure on the ulnar side, and when you do this, then you'll notice a flushing of the hand within 5 to 15 seconds. And this denotes that there's good blood flow, that the artery on that side is patent. If the artery on that side is not patent and you do not get this flushing, then ABG does not need to be performed in that hand, because when you perform an ABG, you're basically occluding the circulation that's going to the hand. So if you don't have a patent ulnar and you stick the radial, you're going to cause some issues, or your respiratory therapist is going to cause some issues. All right, so we have metabolic acidosis and metabolic alkalosis. With metabolic acidosis, our pH is going to be low and our bicarb is going to be low. Our CO2 could be normal or it could be low, just pending. The causes of this metabolic alkalosis, we could have a fixed accumulation of acid, and this is known as a high anion gap metabolic acidosis. Things that can cause this are diabetic ketoacidosis, starvation, a buildup of lactic acid, or the late stage of salicylate poisoning. The late stage of salicylate poisoning. A normal anion gap metabolic acidosis is caused by a direct loss of bicarbonate, and we lose our bicarbonate in our stool. So if a patient has severe diarrhea, their bicarbonate hasn't had the time to reabsorb in the lower intestinal tract. Your patient could have a lower intestinal fistula, a ureterostomy. They could have diuretic therapy, and certain diuretics, so like your potassium-sparing diuretics, they can cause a metabolic acidosis, not your loop or your thiazide diuretics. Your potassium-sparing diuretics are going to be a cause for metabolic acidosis. And a patient could also have early renal failure, which is a cause. Once a patient develops chronic renal failure, they could chronically be in metabolic acidosis. So the severity of metabolic acidosis is variable. In metabolic acidosis, I kind of think of everything as slowed down when it comes to our mentation. So changes in level of consciousness. We have confusion, drowsiness, altered LOC, or level of consciousness. Again, they're acidotic and their potassium is going to be high. They could have nausea, vomiting, diarrhea. Please do not confuse that they could have nausea, vomiting, diarrhea, because you can also have nausea, vomiting, diarrhea in alkalosis. So the diarrhea could be a causative factor of the acidosis, and the nausea, vomiting is a side effect of the acidosis. Their blood pressure could get low. They could have vasodilation, which is warm, flushed skin. These things don't normally happen until the pH is below 7, but when the pH is below 7, they could have flushed skin and decreased cardiac output. So how do you fix metabolic acidosis? Well, you have to treat the underlying cause of it. So if it's diabetic ketoacidosis that's causing it, the treatment is going to be insulin. They'll be on an insulin drip. If the treatment is, or if the cause is severe diarrhea, we need to make them stop having severe diarrhea. If the cause is a certain diuretic, then we need to stop the diuretic. Then we have metabolic alkalosis. And so with metabolic alkalosis, the mentation is kind of sped up. So they're dizzy, they're irritable, they're anxious, and they can also be confused. They could have dysrhythmias from the fact that the potassium is low. They, again, could have nausea, vomiting, diarrhea. A cause of metabolic alkalosis is volume depletion in the GI tract, so prolonged vomiting. Please, prolonged vomiting, not vomiting once or twice, but prolonged vomiting. So vomiting for days can cause metabolic alkalosis. Gastric suctioning, NG suctioning, can cause metabolic alkalosis. And the reason these things cause metabolic alkalosis is because you're removing the hydrogen ion concentration from the belly. Anything that promotes a loss of potassium, such as diuretic therapy, your thiazides, your furosemide, because loop diuretic is a furosemide, those cause potassium loss the way they work. And then we can have alkalosis from excessive alkali ingestion, such as antacids. You can get alkalosis, metabolic alkalosis, with maybe a patient went into a code situation, and they went into that code situation because of respiratory arrest. They were acidotic. They were given sodium bicarb to help correct it, and it made them alkalotic. And again, the severity is going to vary, and the compensation is going to be hypoventilation. So, how do we treat it? Well, we treat the underlying cause. So if the underlying cause was prolonged vomiting, we're going to need to replace acid so that will correct. If the cause was hypokalemia, then we need to replace potassium. So remember, metabolic acidosis is a low pH and a low plasma bicarb concentration. The body compensates by Kussmaul respirations, which is a hyperventilation, deep labored hyperventilation state. The causes of this, you have two main causes. You have a increase of acid, so like diabetic ketoacidosis, starvation, lactic acid buildup, and then you have a loss of bicarb, so severe diarrhea. Again, your symptoms are varied, and they're going to depend on how severe your acidotic state is, and you're going to treat the underlying disorder. With metabolic alkalosis, you have too much bicarbonate, so your pH is high, and you have a high plasma bicarbonate. The causes of metabolic acidosis, the causes of metabolic alkalosis are a loss of GI volume, so prolonged vomiting, NG suctioning. Another cause is anything that could cause you to be hypokalemic, so certain diuretic therapies, your loop diuretics, your thiazide diuretics, they promote excretion of potassium. If you have a patient that takes way too many antacids, they could become metabolic alkalotic. Or if you have a patient that arrests and you coat him and give him sodium bicarb, that can make that patient alkalotic. How does your body compensate? Your body compensates by hypoventilation because it wants to get the alkalotic state down, so it's going to build up your CO2. And then again, it's managed by treating the underlying disorders. Then we have respiratory acidosis and respiratory alkalosis. With respiratory acidosis, our pH is going to be low and our CO2 is going to be high, and then our bicarb is either normal or high. The cause is inadequate excretion of CO2, so an example could be a foreign object aspiration. Our CO2 builds up because we're hypoventilating. Sedative overdose, our CO2 builds up because we're hypoventilating. Our diaphragm could not be working correctly, and so our CO2 builds up because we're hypoventilating. We could have COPD exacerbation. Again, our CO2 builds up because we are hypoventilating. Or any disease that causes respiratory muscles to not work correctly. Your signs and symptoms of this. So hypoventilation, it's the big sign. And then it can lead to hypoxia. Dyspnea, you could have dysrhythmias due to your potassium buildup. You could have rapid, shallow respirations. Your body is going to be hyperkalemic because you're acidotic. Mentation changes such as drowsiness, dizziness, disorientation, muscle weakness, hyperreflexia. And then we compensate with our kidneys. So we're going to absorb the bicarb. Our kidneys are going to absorb the bicarb, and it's going to excrete hydrogen ions. And that's respiratory acidosis. The way we treat it is going to be directed at our cause. So, for example, if it's a sedative overdose, we're going to give the antidote, which is Narcan. If the acidosis state was caused by a foreign object aspiration, we need to get the foreign object out to keep the patient from hypoventilating and eventually going into shock. If the issue was caused by a diaphragm paralysis, then we might need to ventilate the patient until we can get that diaphragm working correctly. We also are going to give bronchodilators to help dilate the bronchioles of the pulmonary system to help the patient breathe better. Pulmonary hygiene issue, so we're going to give them adequate hydration to help clear the tract, and supplemental O2 if it's needed. So respiratory alkalosis, we're going to have a high pH and a low CO2, and then our bicarb is normal or low. Causes of respiratory alkalosis, hyperventilation, so extreme anxiety, the early phase of salicylate toxicity, a high fever, and then ventilator settings that are poor. Some signs and symptoms of respiratory alkalosis. Well, we could have lightheadedness, and this is caused by vasoconstriction and decreased cerebral blood flow. Our concentration is poor also because of this decreased cerebral blood flow. Our head is in a mental fog. We could have numbness and tingling in our extremities because of decreased calcium. Because of the low potassium, we could have tachycardic issues, dysrhythmias. We're going to be prone to seizures because of our calcium. And then the way that we compensate is with our kidneys, and they help rid the body of the bicarb. And then again, the treatment is going to be aimed at the cause. So if the cause is because somebody was anxious, then we want them to breathe slower. So respiratory acidosis is too much CO2. Your pH is low, your CO2 is high. It's always going to be due to hypoventilation, so you don't excrete the CO2 correctly. What causes it? Sedative overdose, foreign object aspiration, diaphragmatic paralysis, COPD exacerbation, anything that impairs respiratory muscles. Our manifestations are variable. Just depends on how severe the situation is. We could have chronic respiratory acidosis, as in COPD. Going to compensate with our kidneys, and they are going to compensate by absorbing our bicarb and excreting our hydrogen ions so that we get rid of the acid. And then again, our treatment is going to be directed at the cause of the hypoventilation. Then with respiratory alkalosis, our pH is going to be increased and our CO2 is going to be low. Again, the causes are hyperventilation. So anything that can cause extreme anxiety. The early phase of salicylate toxicity, because the drug tells our brain to breathe faster. If a patient has a high fever, they can get alkalotic. And then poorly controlled ventilator settings. Manifestations, again, are variable. The big respiratory ones are the fact that you're hyperventilating, so you're going to be tachypnic, and then you're going to be in a mental fog for neuro with poor concentration. Tingling and numbness because your calcium is low. Tingling and numbness because your calcium is low. Compensatory mechanisms, well, we compensate with our kidneys, and we compensate by getting rid of the bicarb and retaining our hydrogen. And then again, our treatment is going to be aimed at what's going on. So points to remember. You are more acidic the lower your pH is. You're more basic the higher your pH is. If your pH is normal, you're fully compensated. If your CO2 is off, it's going to be a respiratory disorder. If your bicarb is off, it's going to be a metabolic disorder. If your CO2 and bicarb are off, and then your pH is also off, you're going to be partially compensating. Remember that the kidneys and lungs compensate for each other. The kidneys are slow, the lungs are fast. The lungs compensate for metabolic disturbances by changing our carbon dioxide excretion. And then the kidneys compensate by altering the bicarb retention and hydrogen ion secretion. There's the references. I hope you've enjoyed this. I will see you later.